Hydropneumothorax means the simultaneous presence of both air and fluid within the pleural space. Pneumothorax alone contains air. Pleural effusion contains fluid. Hydropneumothorax contains both. The air-fluid interface occurs when air accumulates above pleural fluid. This produces a characteristic horizontal air fluid level on an upright chest radiograph. Hydropneumothorax is a radiological and anatomical description, not a final etiological diagnosis. The clinician must still determine why both air and fluid are present. Etiology: our infectious causes are tuberculosis, bacterial pneumonia, pleural infection and empyema, gas-forming organisms, necrotizing pulmonary infection. Tuberculosis is particularly important in endemic regions such as India. Traumatic causes of chest injuries include blunt chest trauma, penetrating chest trauma, traumatic lung injury, and esophageal injury when clinically appropriate. It's important to differentiate hydropneumothorax from hemopneumothorax. Iatrogenic causes of hydropneumothorax include thoracentesis, pleural procedures, chest drain procedures, central venous procedures, lung biopsy, and mechanical ventilation or barotrauma. Malignancy causes: lung cancer, pleural malignancy, necrotic tumors, bronchopleural fistula associated with malignancy. Bronchopleural fistula is an important mechanism of persistent pleural air. Other uncommon causes include ruptured pulmonary abscess, ruptured hydatid disease, esophageal rupture, and post-operative causes. When you see a hydropneumothorax, don't simply ask how much air and fluid are present. Ask, what created the communication that allowed air to enter the pleural space? The lung has an inherent tendency to recoil inward, while the chest wall tends to expand outward, producing negative intrapleural pressure. When a communication develops between alveoli and pleural space, atmosphere and pleural space, or another pathological source and pleural space, air can enter the pleural cavity. In hydropneumothorax, fluid simultaneously occupies part of the pleural cavity. Air compresses the lung. Fluid compresses the lung. Together, they reduce effective ventilated lung volume and can produce significant respiratory compromise. Hydropneumothorax presents with symptoms such as sudden or progressive dyspnea, pleuritic chest pain, cough, fever, and constitutional symptoms. Hemoptysis may also be present when relevant. A detailed history is crucial for respiratory cases. Look for tuberculosis exposure or previous TB. Ask about pneumonia, trauma, and recent thoracentesis. Inquire on central line placement, lung biopsy, or malignancy. Consider immunosuppression, mechanical ventilation, and esophageal disease. Physical findings in respiratory conditions vary according to the relative distribution of air and fluid. In cases of hydropneumothorax, look for tachypnea, tachycardia, and hypoxemia. On examination, you will find reduced chest expansion and altered percussion notes. Breath sounds are often reduced or absent, and in some cases, a succussion splash may be heard. These signs are critical for early diagnosis. Before searching for the cause, determine whether the patient is physiologically unstable. Let's begin our assessment with A for airway. B is for breathing. Check the respiratory rate, oxygen saturation, work of breathing, chest movement, and breath sounds. C is for circulation, pulse, blood pressure, and peripheral perfusion. D is for disability, assessing mental status. And E is for exposure. If there is severe respiratory distress or suspected tension physiology, do not delay life-saving decompression while waiting for a CT scan. Explain that definitive drainage should follow appropriate emergency stabilization. Hydropneumothorax is effectively diagnosed with an upright chest X-ray. It is particularly useful for demonstrating an air fluid level. This horizontal line within the pleural cavity indicates partial or complete lung collapse. This finding is essential for accurate diagnosis and management. Ultrasound is especially valuable for detecting pleural fluid. It is also key for identifying loculations, and it is crucial for guiding pleural procedures. Today, we'll explore thoracic ultrasound, focusing on pleural pathologies. We look for pleural fluid appearing as dark anechoic spaces. Next, check for pleural sliding abnormalities, a shimmering line. Identify the air fluid interface, loculations, and septations. Finally, note underlying consolidation. CT is often the problem-solving investigation. Use CT to evaluate the exact distribution of air and fluid, loculations, pleural thickening, and pleural enhancement. It also helps assess lung consolidation, cavitary disease, and malignancy. And it is key in identifying bronchopleural fistula, trapped lung, and underlying tuberculosis or other structural diseases. Do not drain the fluid and forget to diagnose it. When clinically appropriate, pleural fluid should be evaluated according to the suspected cause. Today, We will discuss pleural fluid evaluation. We begin with appearance, cell count, and differential. Protein, LDH, and glucose are essential. pH is key if infection is suspected. Gram stain, culture, and cytology follow. ADA, AFB, and molecular tests are context-specific. Molecular tests, triglycerides for chylothorax, hematocrit for hemothorax, and amylase for pancreatic issues. The differential diagnoses are pneumothorax, pleural effusion, and hemopneumothorax. Pneumothorax is air without significant pleural fluid. Pleural effusion is fluid without pleural air. Hemopneumothorax is air plus blood, usually after trauma or vascular injury. Empyema is purulent infected pleural fluid, which may coexist with pleural air and therefore produce a hydropneumothorax-like appearance. Lung abscess is an intrapulmonary cavity containing air and fluid. Cavity tuberculosis is an important radiological differential, particularly when the apparent air fluid level could be confused with a pulmonary cavity. Cavitating malignancy is especially when a thick-walled cavity is present. Esophageal rupture is considered when there is severe chest pain, vomiting, systemic toxicity, or mediastinal abnormalities. Always determine whether the air fluid level is in the pleural cavity or within the lung. If the diagnosis is hydropneumothorax, then management depends on three questions. Number 1, is the patient stable? Number 2, is there infection or another dangerous underlying cause? Number 3, does the pleural space require drainage? These questions guide our approach. Management is divided in 3 steps. Step 1, stabilization. Provide oxygen when indicated, establish IV access, and monitor the patient. Administer analgesia, treat hypoxemia, and manage sepsis if present. If tension physiology is suspected, immediate decompression is required. Step 2, pleural drainage. Clinically significant hydropneumothorax commonly requires intercostal drainage because both air and fluid need to be evacuated. This procedure allows for lung re-expansion and prevents further complications. In pleural drainage, selection and position must be individualized. We consider fluid characteristics, loculations, viscosity, air, infection, anatomy, and local expertise. For pleural infection, antibiotics plus drainage is indicated. Currently, BTS pleural guidance supports image-guided pleural intervention. Step 3. Treat the etiology. This includes tuberculosis, bacterial infections, malignancy, trauma, and esophageal rupture. Accurate diagnosis leads to precise treatment and better patient outcomes. What if the lung does not re-expand? This is an important section. The chest tube is functioning, the fluid is draining, but the lung remains collapsed. What next? Possible causes for unresolved pleural issues include persistent air leak and bronchopleural fistula. Trapped lung and pleural peel may also be contributing factors. Consider loculated infected fluid, malpositioned drain, or inadequate drainage. Finally, underlying lung destruction must be ruled out. Persistent air leak, failure of lung re-expansion, organized empyema, or bronchopleural fistula may require thoracic surgical evaluation. Early evaluation can improve patient outcomes. For complex pleural conditions, we consider additional image-guided drainage. Intrapleural therapy is indicated for pleural infections. Surgical options include VATS, adhesiolysis, and decortication. We may also repair bronchopleural fistulas or perform other individualized procedures. Tailoring these interventions is key. Complications are divided in 4 types: immediate, pleural, treatment-related, and long-term. Immediate complications are respiratory failure, hypoxemia, tension physiology, and hemodynamic compromise. Pleural complications are persistent air leak, bronchopleural fistula, loculated effusion, empyema, trapped lung, and fibrothorax. Treatment-related complications are bleeding, infection, drain malposition, re-expansion pulmonary edema, and organ injury during pleural procedures. The long-term complications, these include incomplete lung re-expansion and pleural fibrosis. Also, recurrent pneumothorax and recurrent pleural infection. Let's summarize the topic. Hydropneumothorax. It means air plus fluid in the pleural space. It is a descriptive diagnosis. Always identify the underlying cause. Tuberculosis, bacterial pleural infection, trauma, malignancy, and iatrogenic causes are important considerations. An air fluid level on chest X-ray is classic, but CT and ultrasound can provide crucial additional information. In suspected pleural infection, pleural fluid pH, microbiology, and imaging help determine the need for drainage and escalation. Attention, hydropneumothorax is an emergency. Treat the physiology without unnecessary delay. Persistent air leak or failure of lung re-expansion should make you think about bronchopleural fistula, trapped lung, loculation, drain problems, or underlying lung disease. And finally, never treat the X-ray alone. Treat the patient. Drain the pleural space when indicated. And most importantly, treat the cause. If you found this chapter useful, follow the Pulmocare by Dr. Kalim Khan channel, where we approach respiratory cases systematically from presentation and examination to investigations, diagnosis, differential diagnosis, management, and complications. This is Pulmocare by Dr. Kalim Khan. Keep learning, keep questioning, and keep your clinical approach systematic. Let's summarize hydropneumothorax in 30 seconds. Patient presents with dyspnea and chest pain. Assess ABCs and physiological stability. Chest examination suggests pleural pathology. Chest X-ray demonstrates an air fluid level. Ultrasound confirms pleural fluid and guides assessment. CT identifies the distribution and underlying pathology. Pleural fluid is sent for biochemical, microbiological, and cytological studies. The cause is established. Pleural drainage is performed when indicated. Appropriate antibiotics or disease-specific treatment is started. Post-operatively, we monitor the drain function and air leak. Failure of lung re-expansion triggers reassessment for fistula, trapped lung, loculation, or inadequate drainage. Thoracic surgery is involved when indicated. Remember, the X-ray tells you what is present. Your history, examination, imaging, and pleural fluid analysis must tell you why it is present. If you found this chapter useful, follow the Pulmocare Pulmonology Case Evaluation series, where we approach respiratory cases systematically from presentation and examination to investigations, diagnosis, differential diagnosis, management, and complications.